Hello, everybody. My name is Tyler Wilson. I'm a fourth-year medical student from Drexel University. I spent the year working with Stanford's ENTRUST and global engagement teams, and today I'll be discussing the ENTRUST learning platform and its potential impact on global surgical education. ENTRUST is supported by seed grant funding from the Division of General Surgery, Department of Surgery, APDS, and the Center for Innovation in Global Health. There's a global need for accessible, evidence-based learning tools to support surgical education. Our goal for this study was to evaluate the usability and feasibility of the ENTRUST learning platform in addressing this educational need in a low-resource setting. ENTRUST is a virtual online patient simulation platform that was developed in collaboration with the Stanford Department of Surgery and the Alt Games Lab at UC Santa Cruz. A learner can virtually work up a patient by taking a history, performing a physical exam, and ordering labs, imaging, and interventions. One may even follow a patient's vital signs and see changes as orders are completed. Cases can be adapted to reflect practice environment and setting. Once stabilized, the learner will choose a disposition for their patient. Both the operating room and ICU are pictured here. This will trigger a multiple choice style question set with question explanations provided. While ENTRUST has been used successfully in a testing format, it is yet to be utilized as a teaching platform. The University of Global Health Equity, or UGHE for short, is a relatively new medical school in Rwanda. Building on relationships from previous partnerships, UGHE indicated a desire for curricular support from Stanford's Department of Surgery. A partnership was formed between UGHE and Stanford's ENTRUST and global engagement teams, who have worked for the past year to evaluate the feasibility of ENTRUST in delivering UGHE's surgery clerkship curriculum. In terms of methods for our study, 18 UGHE medical students were proctored to complete 2 ENTRUST cases, which included appendicitis and inguinal hernia. Following the activity, they completed a survey which utilized the System Usability Score, or SUS, the Test of Online Learning Success, or TOOLS, Likert responses, and open-ended responses. We calculated descriptive statistics for the SUS, tools, and Likert responses, and qualitative analysis was performed inductively in an iterative fashion for open-ended responses. For demographics, the mean age for our study was 21.7 years with a female predominance. Native language was predominantly the native language of Rwanda. English proficiency was high, with the majority of students either native, bilingual, or full professional in English. And just under half the students had prior video game experience. The test of online learning success, or TOOLS for short, is a score that was developed to provide a clear picture of student characteristics that lead to successful online performance. The computer skills subscore in particular evaluates a user's comfortability with using online software such as ENTRUST. The subscore consists of 11 questions and is scored from 0 to 5, with 5 being the highest possible score. Green on the right indicates the top quartile of this score, which is a maximum score of 5. UGHE students demonstrated a mean tools computer skills score of 5, which indicated that students were more than prepared for online learning. The System Usability Scale, or SUS, is a widely used tool in the software industry. It is used to evaluate systems on how usable its interface is, and scores range from 0 to 100. For context, the iPhone has an SUS of 78.5, where Gmail is 83.5. Remission, which is a popular educational game in the same genre of ENTRUST, has an SUS of 58.5. The previous ENTRUST study, which utilized Stanford surgery residents, revealed an SUS of 82.5, which indicated that ENTRUST was highly usable within the Stanford resident population. ENTRUST also demonstrated high usability within the UGHE student population. The median of 82.5 was the same median SUS found within the Stanford resident population. There was a mean of 81.5 with the minimum of 55 and maximum 100, and standard deviation was 10.9. All this to say that ENTRUST was highly usable within the UGHE student population. Bivariate analysis was performed to evaluate for usability bias related to demographic factors, which included age, sex, English proficiency, and prior video game experience. On the left, you can see the demographics studied. The middle column shows Spearman's row for continuous variables. And on the right, you can see the p-values. No usability bias was identified. However, given the limitation of our small sample size, we were unable to conclude that associations between variables, such as the SUS score and English proficiency, would not be detected in a study with greater statistical power. Likert question responses are summarized here. Strongly agrees in dark green, while strongly agrees in dark green, while agrees in light green, and neutral is in yellow. Mean Likert scores and standard deviations for the individual questions are seen on the right. Results indicated a perceived educational benefit of ENTRUST and a desire for additional ENTRUST cases. Of note, 94% of respondents strongly agreed that they enjoyed completing ENTRUST cases, while 94% also strongly agreed that they would like to complete additional ENTRUST surgery cases. Qualitative analysis was performed in an inductive fashion for open-ended survey responses. Here, the students were asked, what did you like about the ENTRUST surgery modules? Main themes identified included realism, education, organization, challenge, and feedback. For example, for realism, and I quote, I liked the way it simulated real-life patients, for example, heart rate and blood pressure rising up in real time. Respondents were also asked, what did you dislike about the ENTRUST surgery modules? Responses were limited, with many students responding with, quote, nothing, period. Response themes, which consist of limited feedback and complexity, were limited to 2 individual respondents. For example, for complexity, and I quote, it seemed a little bit complex. In conclusion, the ENTRUST platform demonstrated high usability within a population that has high computer literacy. There is no usability bias identified in this limited sample size related to demographic factors. Likert responses demonstrated high perceived value of ENTRUST and indicated a desire for additional ENTRUST cases. Qualitative responses were overwhelmingly positive and showed educational value. From this data, we can infer that there's initial feasibility for the use of the ENTRUST learning platform at UGHE and in similar settings. Due to the success of our pilot study, we'll be continuing with our plans for an ENTRUST-based surgical clerkship curriculum at UGHE. We aim to launch in the fall of this year with a total of 16 surgical cases specific to the UGHE practice environment. There will also be continued development of the ENTRUST learning platform, including improved question and scoring feedback. We eventually hope to expand the ENTRUST learning platform via additional educational partnerships and local practitioners, addressing the need for accessible educational tools. Thank you very much. Any questions?
Good afternoon, everyone. I'm Kirbi Yelorda. I'm a PGY4 here at Stanford. Today I'll be discussing social risk and survival among patients with advanced colorectal cancer. Social determinants of health or social risk are associated with poor 30-day outcomes and reduced uptake of care amongst patients with colorectal cancer. Previous studies, however, have relied on aggregated zip code level data rather than individual social determinants of health, things like education and income. Excuse me, patient-reported data has been limited to only short-term outcomes. Our purpose was to examine the impact of individualized and co-occurring individual-level social risk factors and their effect on long-term survival among patients with advanced colorectal cancer. To do this, we linked patient-reported survey data to registry-reported long-term cancer outcome data. Inclusion criteria were stage 3 colorectal cancer patients who were at least 18 years old and had undergone surgery in the past 4 months at the time of survey deployment. We utilized 8 social risk factors: partnered status, preoperative employment, annual income, health insurance, comorbidities, health literacy, whether or not they were adult caregivers, perceived discrimination. And for the perceived discrimination, we used the everyday discrimination scale, which gauged how often participants experience discrimination in their everyday lives. This was according to things like age, sex, race, marital status, weight, even speech. Health literacy was represented by the mean of 3 items, previously validated in clinical populations. These were slightly adapted to focus on difficulties patients may face in understanding their colorectal cancer or their colorectal cancer care. Lastly, adult caregiving was defined as providing care for at least one spouse, parent, or adult relative who lived in the respondent's home. These social risks were dichotomized, and we defined cumulative social risk as the sum of risk components. So between 2011 and 2014, we partnered with surveillance epidemiology and end-result registries of Georgia and metropolitan Detroit to conduct a survey of newly diagnosed stage 3 colorectal cancer patients. We compared cumulative and individual social risk components. Hazard ratios for mortality were calculated to assess overall 5-year survival rates. We then adjusted for age, race, sex, and receipt of chemotherapy. We started with 1,900 eligible patients, and of those, 1,300 were located and returned the survey. That's a response rate of around 68%. A total of 1,100 patients were analyzed. Just over half of our respondents were female. The mean age was 63. 24% were Black, 68% were white, and 77% had undergone chemotherapy. So that brings us to our social risk factors. Of our 1,100 respondents, 60% were unpartnered, 74% were employed, 42% made at least $50,000 a year. The vast majority, or 80%, had either private health insurance or Medicare. 54% had one or fewer comorbidities in addition to their colon cancer, and 85% had adequate health literacy. 14% identified as adult caregivers, and lastly, 63% reported never perceiving discrimination, while 36% reported experiencing discrimination either rarely, sometimes, often, or very often. So these tables represent the 5-year survival rate for our respondents. 66% of our cohort were alive at the end of 5 years, which is pretty well aligned with known studies for stage 3 colorectal cancer. When looking at race, 66% of both Black and white respondents were alive at 5 years, and 72% of others. Lastly, looking at gender, 64% of males and 69% of females were alive at the 5-year mark. So this figure demonstrates hazard ratios for individual social risk at 5-year survival. So this is the line of statistical significance here vertically. As we know, if the horizontal lines cross the vertical lines, then the hazard ratio is not statistically significant. So you can see that with the exception of adult caregiving and perceived discrimination, all other risk factors did not cross the vertical line, and they are statistically significant. So this figure is looking at cumulative social risk and 5-year survival. Cumulative social risk was considered as a continuous variable in our model, but to visualize the effect, it was categorized as 0 through 6+ in a Kaplan-Meier plot. Because no participants reported the presence of all 8 risk factors, and less than 2% reported the presence of 7 risk factors, the 6 through 8 categories were condensed into 6+. So patients who had no social risk are here in red. 1 is in gold, 2 is in green, 3 is in teal, 4 is in blue, 5 is in purple, and 6+ is in pink. So what we're seeing that is pretty reliably, the more cumulative social risk a patient has, the lower the long-term survival probability becomes. In our multivariate analysis, the hazard ratio is 1.12 with a p-value of 0.001. So in short, individual risks do have an impact, but it's really the cumulative risk that can have a detrimental impact on these patients. In conclusion, with a robust analysis, we found that cumulative social risk was associated with lower long-term survival after treatment for stage 3 colorectal cancer, even after adjusting for age, sex, race, and receipt of chemotherapy. Assessing social risk may help identify patients with colorectal cancer who are at higher risk for mortality and who may benefit from supportive programs to help mitigate disadvantageous social determinants of health. In terms of next steps, we're currently gathering data to look at cancer-specific survival, and we're identifying mechanistic relationships between social risk and poor cancer outcomes. I'd like to thank my research mentor, Dr. Morris, and everyone who worked on this project at Aspire. Thank you for the privilege of the podium.
I'm Daniel Ahn. I'm a PGY1 in the general surgery program here. Thanks for the opportunity to present my research. All right, so between 600 and 800 children are listed for liver transplant every year in the US, and there's an approximate 10% mortality rate. Now, children can be listed with either a MELD or a PELD score. MELD is for ages 12 years and older, and it ranges from 6 to 40. And then PELD is for ages under 12 years. Both the MELD and PELD score describe are ways to predict your pre-transplant mortality risk, but they're also used by the OPTN to determine your placement on the waiting list. Now, MELD and PELD are developed from very different cohorts, but they're actually directly compared for the same pool of livers without any correction factor. And you can imagine this is a huge problem because in a study in 2018, it showed that PELD scores underestimate mortality risk by as much as 17% in children with high scores. Now, inaccuracy of PELD has been known for a long time, even since 2002 when it was first implemented. And due to lots of concerns about low accuracy, there have been a lot of exceptions and status upgrades for the PELD score. In fact, from 2002 to 2013, the PELD exception applications have increased fivefold. Now, this brings up the question, what is the utility and the purpose of exceptions? So exceptions should be reserved for patients whose pre-transplant mortality risk is poorly represented by their MELD or PELD score. And we have standardized exceptions, which are given automatically to patients with certain diagnoses. But there are also some conditions that are not well described in terms of their pre-transplant mortality risk, and often undergo case-by-case review of how many points they should be receiving. And this is described by non-standardized exceptions. Now, due to the poor accuracy of PELD scores, non-standardized exceptions have increased dramatically. As a result of this, in 2019, in May, the OPTN implemented something called the National Liver Review Board and accomplished three things. First thing, it established a centralized review of exception requests. It also set allocation thresholds for standardized exceptions, and it provided guidance documents on what constitutes a non-standardized exception request. Despite these changes, there still might be overcrowding of a lot of candidates at the highest priority levels, and that might crowd out the sickest patients. So the purpose of my study was first, determine whether patients with non-standardized exceptions have a difference in pre-transplant mortality risk compared to patients without them, and to determine whether exceptions actually affect the accuracy of the pre-transplant mortality risk, and finally, to determine whether the NLRB has affected these changes at all. So data source was the SRTR standard analysis files. Our population was active pediatric candidates added to the waitlist between June of 2016 and September of 2021. We had several exclusions. This included status 1, if you were placed on multiple organ transplants simultaneously, and if you had a primary diagnosis that was eligible for an automatic standardized MELD-PELD exception without review. And our outcome was all-cause pre-transplant mortality. Now, for the purpose of the study, we had two scores. There was an laboratory and an allocation MELD-PELD score. Laboratory score is determined by your clinical values like INR and bilirubin, and allocation score is a score that's used by the OPTN to determine your placement on the waiting list. Now, if you don't have an exception, your allocation and your laboratory scores are the same, but if you do have an exception, your allocation scores increase by a certain amount and is greater than your laboratory score. We did several statistical analyses in our project here. We did a time-dependent analysis. We understood that MELD-PELD scores and your exception status are dynamic variables that can change throughout your time on the waitlist. So we did a mixed effects Cox proportional hazard with those at time-varying covariates. And our model calculated the hazard ratio associated with the absence of a non-standardized exception. We also calculated Harrell-C indices to assess the performance of allocation system and rank ordering candidates by the mortality risk. And finally, we also looked at the proportion of candidates before and after the creation of the NLRB, and we did some analyses there too. This is our final study cohort selection. After all the exclusions that we can see on the right-hand side, we had 2,026 patients in our study cohort. 403 of them here had an exception that was approved within 1 week of listing, and 1,623 did not have one within 1 week. But among this group, about 800 of them received an exception at some time during their waitlist. So in total, almost 60% of patients had an exception at least once during their waitlist. This is our demographics table here. We stratified patients by whether or not they had an exception at the time of listing or afterward or not. There's not really many differences in terms of significant differences between the groups with the exception of age group. But I do want to direct your attention to the laboratory and allocation MELD-PELD score. So between the two groups, they didn't have a significant difference in their scores. But you can see here in the allocation MELD-PELD, those who had exceptions had an average increase of 20 points above their laboratory score. And we can see this in the distribution in the next curve here. In green is the allocation or laboratory score of patients without exceptions. In blue is just a laboratory score of patients with exceptions, but you can see a huge rightward shift in the salmon colored distribution where patients had exceptions, their allocation score. And you can see over here, there are actually some patients who even had a PELD score of 70 after their allocation had an exception. This is our main model here. So we looked at the hazard ratio associated with absence of an active exception. And here we can see that if you did not have an exception during your time on the wait list, that was associated with an almost 9 times increased risk of pre-transplant mortality. And this is even after controlling for allocation, MELD, PELD, age group, race, and sex. Next, we looked at the accuracy of the ranking system. So our C index of allocation MELD, PELD, and this includes all allocation scores, was 76%. So another way to describe this is 76% of our cohort study was rank ordered correctly in terms of their pre-transplant mortality risk if we used exception scores. But when we took out the exceptions, it was more accurate. The C index of laboratory MELD PELD scores was 84%. Next, we look at the pre and post policy cohorts. There were about 900 in the seasonally matched pre-policy cohort, 790 in the post-policy cohort here. And during this time period, there were about 1,250 DDLTs or deceased donor liver transplants performed in this time. And we saw that after the creation of the NLRB, the proportion of recipients with active exceptions decreased dramatically from 70% to 43.8%. And this is described in our figure here. In A, this describes the proportion of candidates with exceptions at the time of transplant. And you can see in this gray curve here, a gray box here at pre-policy cohort, it's about 70%. And this dotted line here describes the creation of the NLRB in May 2019. And there's a dramatic decrease in patients who had an active exception at that time. And this is basically just the absolute number of that. So in total, we did a time-dependent analysis, and this is a novel and more comprehensive quantification for pre-transplant mortality risk. We saw that the absence of a non-standardized exception at any time during the wait list period was associated with an almost 9 times increased risk of pre-transplant death. And our allocation system would be better at rank ordering if exceptions were not given at all. The C index improved from 76% to 84%. The NLRB appears to be pretty effective initially. The proportion of recipients with exceptions at the time of listing at the time of transplant went down, but they're still really highly prevalent, more than 40% still after 2019. And as always, there should always be review on exceptions, on how are they awarded, and there should be more evidence-based work on what score correlates with what specific type of pre-transplant mortality risk. I'd like to thank the Healthcare Ethics and Organ Allocation Lab at the University of Chicago. This is where I started my research here. And I'd love to thank my amazing 3 mentors, Dr. Barth, Dr. Gallo, and Dr. Parker. Thank you.
So carotid artery stenosis is predominantly due to the accumulation of atherosclerotic disease at the carotid bifurcation. In general, it suspects about 1 to 2% of the population and up to 3% in octogenarians. Vulnerable plaque is prone to plaque rupture and consequent embolism of atherosclerotic debris and thrombus to the brain, responsible for about 10 to 12% of all ischemic strokes and TIAs. Given the risk of embolism and stroke, revascularization is indicated in patients with greater than 50% stenosis symptomatic to prevent recurrence, and greater than 80% stenosis in asymptomatic patients. So 2 broad categories of carotid artery revascularization include carotid artery endarterectomy and carotid artery stenting. CEA, or carotid endarterectomy, involves open exposure of the carotid arteries, arteriotomy, and removal of atherosclerotic plaque. Randomized control trials comparing CEA to medical management have consistently shown an improvement in mortality and stroke rates. ACAS compared asymptomatic patients with CEA and medical management and showed a 6% absolute risk reduction in 5-year ipsilateral stroke rates. And NASIT showed a 17% absolute risk reduction in 2-year ipsilateral stroke rates. In patients unable to tolerate open operation, carotid artery stenting is indicated for revascularization. CAS comes in 2 flavors. Traditionally, it has been done through a percutaneous transfemoral approach. And this approach involves manipulation of the aortic arch and traversal of the carotid lesion with a consequent risk of perioperative stroke. Recently, transcarotid artery revascularization, or TCAR, which involves open access to the common carotid artery, mitigates the risks of a transfemoral approach by employing flow reversal prior to stent deployment. So while perioperative outcomes comparing CEA and CAS have been well studied, the long-term outcomes and durability of these procedures remain to be evaluated. The CREST trial, which compared CEA to transfemoral CAS, demonstrated a significant decrease in perioperative stroke with CEA. However, CEA was associated with an increased risk of MI. The Roadster 2 trial, which evaluated the safety and efficacy of TCAR, reported a composite stroke death and MI rate of 1.7%, which is on par with contemporary outcomes of CEA. So interestingly, the CREST trial found no significant difference in their primary endpoint of composite stroke mortality and MI at 4 years between CAS and CEA. However, contemporary long-term outcomes, particularly the risk of reintervention between revascularization modalities in the area of TCAR, remain to be evaluated. So to address this, we used real-world VQI data matched to Medicare claims data with the vascular implant surveillance and implantation network, or VISION database. We looked at patients from 2016 and 19 and used one-to-one greedy propensity matching to compare cohorts, both CEA in all CAS patients and TCAR versus transfemoral carotid artery stenting. We then used time-dependent Cox regression models to compare outcomes. Our primary outcome was ipsilateral reintervention, and our secondary outcomes were stroke and mortality. So in the VISION VQI dataset, we identified over 100,000 patients undergoing CEA or CAS. After exclusion of patients as seen on the right, we identified over 20,000 patients who underwent CEA and nearly 7,000 patients who underwent CAS, with roughly equal distribution of transfemoral and transcarotid stenting. So on initial comparison of CEA and all CAS, we identified 4,705 patients in each cohort after propensity matching. As you can see on the left, in the unmatched comparison, there's a higher prevalence of CAD, COPD, CKD, and a high ASA class. There's also an increased degree of stenosis and increased prevalence of patients on antiplatelets. With the exception of CAD and a prior history of radiation, we're able to account for these discrepancies after propensity matching. We then looked at the risk of stroke and mortality on CEA versus all CAS patients over a period. On the left here are Kaplan-Meier curves depicting freedom from stroke and mortality, and on the right are forest plots illustrating hazard ratios for the two outcomes, both within and beyond 6 months. Confirming prior observational studies, we found a significant increase in risk of early stroke with a hazard ratio of 2.4 in patients undergoing CAS, but no difference beyond 6 months. Meanwhile, the risk of mortality was greater in patients undergoing CAS within both time periods. So over the course of 3 years, we did not find a significant difference in the risk of reintervention. However, analysis of the first 6 months demonstrates a significantly increased risk of reintervention in CAS compared to CEA, with some separation of the Kaplan-Meier curve as shown in the inset. We next compared transfemoral carotid artery stenting and TCAR with over 2,000 patients in each cohort. Here, propensity matching allowed mitigation of all discrepancies in patient characteristics observed in the unmatched cohorts. Again, consistent with prior observational studies, we found an increased risk of stroke and mortality in transfemoral carotid artery stenting, largely driven by an increased risk within the first 6 months. The risk of mortality was present in both within the first 6 months and beyond. Surprisingly, when we looked at the risk of reintervention between the two cohorts, we found that transfemoral carotid artery stenting carries a significantly increased risk of reintervention with a hazard ratio of 2.3 beyond 6 months. You can begin to appreciate the separation of the KM curves around 30 months. So here we demonstrated in all comers, there's an increased mortality, stroke, and reintervention benefit with CEA. And this appears to be driven largely by inferior outcomes with transfemoral carotid artery stenting specifically. And TCAR appears to have improved durability when compared to transfemoral carotid artery stenting over a period of 3 years. In conclusion, CEA portends a lower rate of reintervention stroke mortality compared to CAS. Patients undergoing TCAR have lower rates of reintervention beyond 6 months, suggesting increased durability of TCAR. And amongst all procedures, CEA appears to be the most durable procedure, with TCAR more durable stenting procedure. With that, I'll take any questions. Thank you.
Thank you for the opportunity to present. So when it comes to surgical prehabilitation, studies have shown that patients often prefer personalized, flexible, and home-based programs. However, adherence in unsupervised settings is often not very high. Lack of family support and medical issues have been reported as important barriers to adherence. But in order to develop a patient-centered prehabilitation program, we need to have a more comprehensive understanding of their barriers and facilitators. So the aim of our study was to identify and explore barriers and facilitators of adherence to surgical prehabilitation among patients undergoing major gastrointestinal surgery. For that, we performed a mixed method study with explanatory sequential design. So we first collected quantitative data, and that informed the collection of our qualitative data, and then we integrated the findings. Our study was nested in a prehabilitation randomized controlled trial, and our patient population consisted of patients who were randomized to the intervention arm. So patients who were going to receive prehabilitation through a mobile app on their phone. For the quantitative part, these patients answered a questionnaire about barriers to physical activity and healthy eating. For the qualitative part, we used voluntary sampling to recruit a subset of those patients for a semi-structured interview focused on their experience with the program. So we interviewed patients until we reached thematic saturation, and we individually coded the interview transcripts, deriving themes from the data. And then for interpretation, we correlated the quantitative findings from the surveys with the themes that emerged from the interviews, and then we mapped them to the theoretical domains framework. The theoretical domains framework synthesizes a series of theories of behavior change, and in this framework, there are 3 main components to behavior: capability, opportunity, and motivation. Each of these components has 2 domains, so we use this framework to identify key factors of behavior that could be targeted in future prehabilitation programs. Our prehab program was delivered through this mobile app and had 2 components: physical activity and nutrition. For physical activity, patients could choose from different levels of strength exercises. They also received a fitness tracker and were encouraged to walk at least 5,000 steps a day. For nutrition, they were mostly encouraged to follow a Mediterranean diet, and they could find instructions and also recipes in the app. So these are the demographics of the patients who answered the survey. 57% were female, the median age was 61, and the majority of the patients were white. The survey about barriers included these items. The most frequently reported barriers to physical activity were lack of motivation, pain, and medical issues. For healthy eating, the questions were pretty similar, and the most common barriers were lack of motivation, lack of information, and also medical issues. For the qualitative part of the study, we interviewed 15 participants. 9 patients were white. Most had more than 45 years old, and almost all of them were white. And in this graph, we can see the main themes that emerged from the interviews regarding the barriers to prehab adherence. One of the most frequent was the psychological relationship to food. So this patient, for example, said that when you get depressed, which is natural when you're going through something like that, you're more indulgent and you have less energy to prepare like healthy meals. You're just sure, like, I love a piece of pizza. And I think lots of us can relate to that. Another common thing was the baseline aversion to exercise and healthy food. Like this patient who said, my parents were all from Oklahoma. So there was pretty much bacon at every meal, and everything gets fried and it tastes good. So that's what I grew up on. And it's very challenging when the patients didn't develop a taste for healthy food. Or for physical activity, like this patient whose friend said that exercising should be like brushing your teeth, just a natural thing. And she said, well, it's never going to be like that for me. As for facilitators, the most common was that patients recognized the benefits of eating healthy and exercising, especially those who had a diagnosis of cancer. Other facilitators were that patients got into a positive cycle where eating better and exercising led to more energy and well-being. So this patient reported that he felt more awake and alert after starting the Mediterranean diet, for example. And having social support was also frequently cited as a motivator. So back to the theoretical domains framework, we were able to map the main themes into 6 of these domains. And they are summarized here in this table. So the first domain was physical, where physical limitations were important barriers to both physical activity and to healthy eating. The second was knowledge. While knowledge could be a facilitator, it could also be a barrier. It was pretty surprising to us that a lot of patients had misconceptions or assumptions about the Mediterranean diet that prevented them from following the recommendations. Like this patient who said he didn't try the diet because he just didn't like fish. Then there were beliefs about capabilities. Several patients reported lack of motivation as a barrier in the survey. But in the qualitative analysis, we saw that participating in the study actually motivated the patients to being more control of their own health. Emotion was mostly a barrier for most patients. Some people saw food as a source of comfort and indulgence, and other patients reported a poor relationship with food in the past. So we asking them to monitor their food intake was triggering. Environmental context and resources were also mentioned. Extreme weather was mentioned as a barrier, while the time-efficient exercises that we provided in the study were mentioned as a facilitator. And finally, we noticed that social influences could be both a barrier or a facilitator, and I think those 2 quotes here illustrate this conflict very well. So one limitation of our study was that patients who opted to participate in the prehabilitation study were probably more likely to engage in physical activity and healthy eating in the first place. We don't know about those who didn't enroll in the study in the first place. And another major limitation was the lack of diversity in the patient population. So, and for next steps, we're definitely trying to address those limitations. Right now, we're trying to interview patients who are refusing to enroll in the study to understand also their point of view. But in conclusion, the study provided valuable insights on how to improve adherence in future prehabilitation programs, such as the importance of assessing patients' environment, beliefs, and baseline knowledge, the importance of personalizing the exercise to accommodate patients with reduced mobility, the importance of accountability and of engaging family members in the prehabilitation too. Thank you, and I'm happy to take any questions.
Thank you for your introduction. This is my great honor to present our work at this conference. Induction therapy is intensive immunosuppression administered at the time of transplant to mitigate the risk of rejection. It has long been debated as to which induction therapy is the most appropriate. However, the optimal induction therapy for pediatric transplant remains unknown due to the limited evidence. This study is NIH-NIAID sponsored prospective multi-center study. 872 pediatric patients underwent transplants at 7 centers in US. After patient selection, considering the data characteristics of this study, 470 patients were retrospectively analyzed. C.C06 study was conducted to assess EBV and immunologic biomarkers associated with post-transplant lymphoproliferative disorders as a primary objective. In order to achieve one of the exploratory objectives, we planned this retrospective study focusing on induction and rejection. The variables included sex, age, ethnicity, pre-transplant EBV and CMV serologies, and induction therapy. Cumulative incidence of rejection was compared with patient death as a competing risk. Here are the representative patient characteristics. The number of patients is 261 in liver transplant, 97 in heart transplant, 79 in kidney transplant, and 33 in intestinal transplant. ATG is anti-thymocyte globulin. Basilikizumab is a monoclonal anti-CD25 antibody. Rituximab is a monoclonal anti-CD20 antibody. Liver transplant recipients were treated with mainly 4 types of induction therapy, such as no induction or steroid induction, ATG, basilikizumab, and ATG with rituximab. In heart transplant, only 1 patient was given basilikizumab. The other patients received no induction or steroid induction and ATG. Kidney transplant recipients were mainly treated with ATG, basilikizumab, and ATG with basilikizumab. Intestinal transplant recipients received mainly ATG, basilikizumab, and ATG with rituximab. We conducted univariable and multivariable analyses for each transplanted organ. In liver transplant, ATG and no induction or steroid induction were significant risk factors for rejection compared to basilikizumab. In the cumulative incidence curve, basilikizumab green line developed significantly less rejection than ATG and no induction or steroid induction. ATG with rituximab orange line had also less rejection rates compared to ATG and no induction or steroid induction. However, ATG with rituximab was administered for specific patients such as highly sensitized patients or patients undergoing ABO incompatible transplant. So in this analysis, the results of basilikizumab are more meaningful than those of ATG with rituximab. In intestinal transplant, ATG was a significant risk factor for rejection compared to basilikizumab. As shown in the cumulative incidence curve, basilikizumab developed significantly less rejection than ATG. In heart transplant, EBV naive recipient and ATG induction were significant risk factors for rejection. As shown in the cumulative incidence curve, ATG developed significantly more rejection than no induction or steroid induction in heart transplant. If the 2 risk factors of EBV naive recipient and ATG induction were combined, the rejection risk was clearly stratified as shown in this figure. Patients with 2 and 1 risk factors developed significantly more rejection than those with no risk factor. Considering that ATG is a strong immunosuppressant that broadly regulates T cells, EBV infection and ATG may have been mutually associated with the development of rejection. In kidney transplant, there was no significant risk factor, presumably due to the low rejection rates compared to the other organs in this study. However, patients with ATG alone or basilikizumab alone developed rejection after transplant, while all patients with ATG and basilikizumab had no rejection within 2 years of kidney transplant. Basilikizumab is a monoclonal antibody against CD25 and specifically blocks the IL-2 receptor alpha chain on activated T cells, which leads to inhibiting subsequent immunological reaction that plays an important role in developing rejection. In contrast, ATG is a polyclonal IgG and blocks T cell membrane proteins such as CD2, CD3, CD4, CD8, and so on, which results in prolonged T cell depletion. ATG broadly regulates T cells, which means ATG is a stronger immunosuppressant compared to basilikizumab. However, it may lead to a higher risk of complications associated with infection, as reported in another paper. Infection can contribute to allograft rejection, both directly and indirectly. Infection may induce highly inflammatory and cytotoxic cellular responses, which can directly increase the risk of rejection. For example, it is well known that CMV infection is significantly associated with rejection. Indirectly, post-transplant infections are commonly treated by reduction of immunosuppressants, which can indirectly increase the risk of rejection. Unlike CMV, there are no reports that EBV is associated with rejection, presumably because 90% of adults are EBV seropositive. So we need to focus on only pediatric patients to elucidate the mechanism. In conclusion, basilicizumab developed less rejection in liver transplant and intestinal transplant than ATG. ATG induction and EBV naive recipient were significant risk factors for rejection in heart transplant. In kidney transplant, there was no significant difference between induction therapy and rejection. However, patients treated with ATG and basilicizumab had no rejection within 2 years of kidney transplant. I'd like to sincerely thank all the excellent members involved in this study and the great research funders. Thank you for your attention.
Thanks for the opportunity to present our research today. We have no relevant disclosures. So delays in liver transplantation have unique consequences for waitlisted infants that include long-term impairments in neurocognition and growth during a critical phase of development. And despite efforts to improve the pediatric priority in liver organ allocation, infant pediatric candidates remained very disadvantaged because of the lack of size-matched donors. Each year in the US, 1 in 10 infants listed for liver transplant will die on the wait list. And when they do receive a liver transplant, infant recipients historically have worse post-transplant outcomes compared to their older pediatric counterparts. In prior research, we demonstrated that inferior technical variant graft survival was found at low volume transplant centers. And as infants with end-stage liver disease in the US continue to die on the wait list and frequently require these technical variant grafts, given the limited availability of size-matched deceased donors, we aim to investigate the role of transplant center volume on patient and graft survival of this vulnerable low-weight pediatric transplant population. And we also sought to identify any discrepancies in waitlist mortality for low-weight pediatric liver transplant candidates based on transplant center volume. So similar to a previous talk, we utilized the SRTR database and identified pediatric liver-only transplant recipients in the United States from 2010 through 2020. Transplant centers were designated as high or low volume based on the average number of pediatric transplants performed per year, greater than 5 for high volume and less than 5 for low volume. And over the 10-year study period, there was a final cohort of 5,208 patients that met our inclusion criteria. 83% of these patients were transplanted at 31 high-volume transplant centers, and 17% were transplanted at 73 low-volume transplant centers. High-volume centers transplanted recipients weighing less than 10 kilograms at a significantly higher rate than low-volume centers at 39% versus 29%. Overall graft and patient survival for recipients less than 10 kilograms and equal or greater than 10 kilograms up to 3 years post-transplant were calculated and compared using Kaplan-Meier curves and log rank tests. And these were further stratified by transplant center volume. We then used Cox proportional hazard models to identify independent predictors of graft failure and recipient death. We also calculated waitlist mortality and compared this between the two groups. Recipients less than 10 kilograms had significantly worse graft survival compared to recipients equal or greater than 10 kilograms, both at high volume and low volume centers. And notably, recipients less than 10 kilograms at high volume centers demonstrated significantly improved graft survival compared to recipients less than 10 kilograms at low volume centers. In fact, recipients less than 10 kilograms at high volume centers demonstrated significantly improved graft survival compared to recipients greater than 10 kilograms at low volume centers. We then looked at patient survival stratified across these different groups, and recipients less than 10 kilograms had significantly worse patient survival compared to recipients equal or greater than 10 kilos, both at high and low volume centers. And notably, recipients less than 10 kilos at high volume centers demonstrated significantly improved graft survival compared to recipients less than 10 kilos at low volume centers. Cox proportional hazard modeling was used to identify independent predictors of graft failure, and receiving a liver transplant at a low volume center was the only covariate significantly associated with graft failure with a hazard ratio of 1.75. Similarly, Cox proportional hazard modeling was used to identify independent predictors of patient death, and receiving a liver transplant at a low volume center was the only covariate significantly associated with patient death with a hazard ratio of 1.74. And receiving a transplant from a living donor was significantly inversely associated with patient death with a hazard ratio of 0.6. Waitlist mortality of pediatric liver transplant candidates less than 10 kilograms added to the waitlist during the study period was significantly higher at low volume transplant centers compared to high volume transplant centers by an extra 12.5 events per 100 person years. So in conclusion, we demonstrate that low weight pediatric liver transplant recipients have inferior post-transplant overall survival and graft survival at low volume centers. We also show that waitlist mortality for low weight pediatric liver candidates is increased by 76% at low volume centers. And these findings highlight need for collaboration between high and low volume centers to reduce waitlist mortality and improve transplant outcomes in this vulnerable patient population. Thank you for your attention. Happy to take any questions.
Good afternoon, everyone. My name is Brian. I'm one of the surgery fellows here, and I'm going to present our work on GLP-1s and their use in bariatric surgery. So shifting a little bit from transplant. And I want to start by talking about the history of GLP-1s because we really come full circle. So for a long time, bariatric surgery has been the only treatment option that we've had for obesity. But it was actually our experience with bariatric surgery that led to the discovery of GLP-1. For patients after a gastric bypass with diabetes, what we see is immediate improvement in their glycemic control. And so that's suggesting a mechanism other than weight loss. And it turns out that that mechanism is contributed by an increase in GLP-1 and other incretins. Once that was discovered, we were able to develop a GLP-1 receptor agonist that works for diabetes. But what we also realized is that for those patients on GLP-1s, they have significant weight loss, approaching numbers that we're actually seeing with bariatric surgery, which is actually pretty revolutionary because we're at a time point now where we have both surgery and medications for obesity. So the question is, how do we use these two together? And that was the main objective of this study. Can downstaging with preoperative medical therapy for obesity improve patient outcomes? For our center here, for our practice, we've been prescribing anti-obesity medications before bariatric surgery for most of our patients. And we wanted to see if the newer GLP-1s were effective in leading to pre-surgery weight loss. So we performed a retrospective cohort study using the Stanford Research Repository, and we identified all adults between 2012 and 2022 who underwent a laparoscopic sleeve gastrectomy or gastric bypass as a primary operation for obesity. And we compared those patients who were never on an anti-obesity medication to those that were receiving a GLP-1 in the year before surgery, with their outcome of interest as their weight loss. We looked at two GLP-1s in particular, liraglutide and semaglutide, which are newer GLP-1s. Liraglutide was FDA approved for the treatment of overweight and obesity in 2014. And we have randomized data that shows an 8% total weight loss with this medication. Semaglutide is a more potent and newer GLP-1, and in randomized trials, patients experienced 15% total weight loss. In our groups, there were 99 prescribed liraglutide and 29 patients prescribed semaglutide. Often, though, we find a barrier is getting insurance approval or cost for these medications, so access is a real issue. Our final cohort ended up including 64 patients on liraglutide and 26 on semaglutide. And I stratified here by low dose and high dose. So the low dose GLP-1s is what's typically indicated for patients with diabetes, and high dose is indicated for overweight or obesity. Comparing our control group to those that were on GLP-1, there were some important differences. So patients on GLP-1 tended to be older patients, were more frequently male. We didn't see any race or ethnic differences between those two groups, but we did recognize that those patients on GLP-1s had a higher baseline BMI, with more patients starting with a BMI over 50. If we look at those medical comorbidities in our groups, not surprising, diabetes was higher in patients on GLP-1, but in general, patients on GLP-1 had more comorbidities, including cardiovascular disease, sleep apnea, liver and kidney disease. And there were, no differences in insurance provider between these two groups. If we look at the trend in utilization of GLP-1 over time, this plot here is showing that for both those patients in our control group and those on GLP-1s, that there was a trend towards more sleeve gastrectomy over gastric bypass over time. And that's actually consistent with national and international data. But what you can see here is that our utilization of GLP-1s has also increased over time in the red bars there. So here are our results from this study. This is a time series showing weight change as a function of time in the weeks before surgery. The gray line represents our control arm. And what you can see is that patient's weight is pretty stable for most of the year. And then within the month before surgery, we see an on average 7-pound weight loss. And for all of our patients that are being considered for bariatric surgery, we put them on a high protein liquid diet in the 2 weeks before surgery. So this is probably what we're seeing right here. On the bottom graph is a cumulative density plot. And this is showing the accumulation of patients on GLP-1 over the course of the year. So about 35% of our patients were on a GLP-1 at the beginning of the year before their surgery, and then everyone else joined in throughout that year. The median time for starting a GLP-1 was 38 weeks in this group. And so that's represented by the red line here. Liraglutide and semaglutide are shown in orange and green. And what we can see here is that after 38 weeks, patients on liraglutide had on average 17 pounds of weight loss, and patients on semaglutide 21 pounds. So significantly and clinically relevant differences between our control group. This is the same data but presented differently. And I want to start by showing an example of what do these numbers translate for a patient. So in our clinic, here's an example patient who's 5'5", 340 pounds with a starting BMI of 55. A 5% total weight loss reduction translates to a 17-pound weight loss, which reduces their BMI to 52. A 10% weight loss reduction translates to 34 pounds of weight loss and a BMI of 49, which is also clinically significant. On the right of our graph for our control, we show our 5%, 10%, and 15% weight loss targets. And we can see is in our control arm, about a third of patients were able to achieve at least 5% weight loss. But if we compare that to our liraglutide or semaglutide group, we see 2 to 3 times higher weight loss in those patients. And if we look at 10% weight loss, 18% in the liraglutide and 19% in the semaglutide achieved 10%. This lastly was a logistic regression looking at associations for achieving those weight loss targets. Being on a GLP-1 was associated with significant weight loss. Being on a higher dose GLP-1 was also significantly associated with weight loss. And then actually being started on a GLP-1 in the 1 year before surgery compared to those patients who were on a GLP-1 prior to the year was associated with a significant weight loss. Looking at the clinical factors associated with achieving these target weights, As I mentioned earlier, age, gender, and starting BMI were different between those two groups. But when we controlled for being on a GLP-1, weight remained a significant predictor of achieving a 10% weight loss. And patients with a BMI greater than 50 had an increased likelihood of achieving that target. So we wanted to explore this relationship a little bit more. And what this is here is an interaction plot showing the proportion of patients who achieved a 10% weight loss target stratified by BMI. And what we can see are non-parallel lines here, suggesting an interaction between higher BMI and achieving and being on a GLP-1. So in conclusion, GLP-1s work in preoperative weight loss. What we see that for our bariatric surgery patients, we were able to achieve clinically significant, clinically relevant weight reductions. For patients with a BMI greater than 50, they had an increased likelihood of achieving these weight loss targets on a GLP-1. And what we suspect is that this could be expanded to other disciplines in surgery, like hernia surgery or cancer surgery. Thank you.